Awesome. Thank you so much. I was trying to figure out how to take notes on everything and share that with the group, but I'm not as good at doing that as I used to
No,
be.
of course, and don't hesitate, anybody, interrupt me with questions. I mean, that's what this is all about. So please don't be polite. Interrupt me at any time with a question,
Thank
you
you.
know. Um, so I forget where I was. Oh, treatment plan, right? So you want all of those things are critical. You need to know those other domains. And Michelle and I were talking earlier, for any of you who are aware of the ProNet project, we have the new psychs, which took the 5 positive symptoms and turned it into 15 positive symptoms. It's a very different assessment. But there are no negative, disorganized, and general symptoms. In a clinical, if you're thinking about providing clinical care, now that means you've got to do other assessments to assess those other domains. And it can be a little bit more difficult, where the SIPS gives you that whole broad spectrum of their total clinical picture, so that you can write a most appropriate treatment plan. Because we know the comorbidity in the prodrome is so incredibly high. It is very rare that you are going to see individuals who only meet CHR. I mean, definitively, I am the human being on the face of the earth who has done the most SIPs. I've done well over 3,500 SIPs in my career. And I have to tell you, a handful of times have I ever seen someone that doesn't have some other mental health disorder. Comorbidity is very, very high. Depression, anxiety, substance use, OCD, ADHD, ASD, it's all there. So you really need to be aware, and people get thrown off. They really struggle with the better explained, because it's going to be there. There are going to be other diagnoses. That in and of itself doesn't negate the CHR diagnosis. You really have to refer to the specific criteria outlined in the DSM-5 for other mental health disorders. You never do it based on a psychodynamic process. So many times when I'm consulting with somebody, they'll say, well, I said they weren't CHR because they have depression, and now they've converted. And, you can't just say somebody's depressed, therefore they're not CHR. It doesn't work that way. And we can talk a little more about that. This is the order of the most frequently endorsed of the positive symptoms. Unusual thought content and suspiciousness are by far the most frequently endorsed of the positive symptoms. They are also the symptoms that most strongly correlate with conversion to psychosis. So if an individual rates a 3 on both P1 and P2, they are at very high risk of converting. Or if an individual rates higher than a 3 on either P1 or P2, they are at the highest risk of converting to psychosis. Perceptual abnormalities is next. Grandiosity and disorganized communication. Now, when you're determining the risk of CHR, there really is a pecking order. The progressive form of APSS is the most likely to convert. And that's where there is an onset or worsening in the past year, okay? So the positive symptom has to be present on average of once a week. And I always stress the on average because very frequently somebody might come in for a SIPS and they've only had the symptom for the last 5 days. But 5 days over a month averages once a week. So really the threshold you're looking for, did it occur at least 4 times in the past month? It doesn't actually have to occur once a week, okay? And then if it onsetted or worsened in the past year, that's the progressive form of APSS. Whereas if it onsetted longer ago than a year without worsening, that's the persistent. And we have tracked conversions where onset of CHR was even 10 years ago. So the risk does remain, but it significantly drops off after the first 2 years of onset. So if you are providing care to this population, you really want to bridge those first 2 years after onset, because that is when they are at their highest risk of becoming psychotic. And the biggest thing about the SIPs, it doesn't matter what they're experiencing. If there isn't a level of distress or interference, it doesn't meet the diagnosis. And a lot of people make a big mistake here. If the person says, oh, it doesn't bother me, but oh yeah, I got to put my headphones on. Interference always trumps distress. If they alter their behavior, you don't have to worry if they're distressed. They wouldn't be altering their behavior if it didn't bother them. So you don't need to query about distress when they share with you, yeah, I isolate, or I can't focus and attend because of the noise in my head, or, I wear headphones to drown it out, or I put my sunglasses on so everything isn't so bright. It doesn't bother me. I'm fine. That doesn't matter. They change their behavior. Interference always trumps distress. And of course, the not better accounted for by another psychiatric disorder is critical. But I want to emphasize strongly, it's not just, oh, they were depressed. Oh, they were sad. Oh, they, were having a bad day. Oh, they were anxious. You can't discount it that way. It literally has to be more characteristic of the diagnosing criteria as outlined in the DSM-5. So that's really critical. And when you follow these things, and I'm going to give you the cheat sheet because that's what this was based on. The Kappa agreement is 0.89, which anybody who engages in research knows that's phenomenal. And it's just critical that that cheat sheet is your Bible. It's got to be in front of you every time you are doing a SIPS. I don't care how many SIPs you do in your career, because it is what is going to get you to that completely reliable diagnosis. And as I said, P1 and P2 are most informative of who is at risk of becoming psychotic. And there is a difference. You need to be aware of this. There is a difference in who meets CHR criteria, how they were recruited. People who come because they are help seeking, they have some mental health concerns and they want clarification. It's different than people who are recruited specifically for studies. Yes, Zachary.
Thank you, and thanks for being here and having us. So I had a question about your language around distress relative to interference. And it sounds like when you use the word interference, you're not necessarily talking about like clinically significant impairment, but rather that the symptom is influencing their behavior in some way. And now that might be just that might be impairing, at a clinically significant level, but it might not be, right? I just wanted to clarify that because, I often see and say like, I think people the symptoms can be influencing behavior, like putting the headset on, like checking the door, checking the lock, something like that. Would this be like really impacting on this individual's life? Maybe, but maybe not, but it's still affecting the way that they interact with the world. It's not containable in the same way that it maybe once was. So if you could just sort of speak to that.
Yeah, that's an excellent point that you bring up. So two things. Yes, it doesn't have to be impairment. It's because of the experience I'm having, whether that's hearing footsteps or seeing a shadow, I change what I'm doing. And what that lets you know is that experience of hearing the footsteps or seeing the shadows is significant enough to that individual that they change what they're doing. It doesn't have to impair it, but it changes, but not a reality check. Okay. A reality check is not a change in behavior. So if I hear something and I go, hey, Zachary, did you just hear that? And you go, no, I didn't hear it. And I go, oh, okay. That's a reality check. That's not a change in behavior. But if I go, hey, Zachary, did you hear that? And you go, no, I didn't hear that. You're lying to me, Zachary. I heard it. I know it was there. Why are you pretending you didn't hear it? That is significant. Okay, so just a reality check. Walking down the hall, I hear my name being called. I kind of look over my shoulder. Anybody there? Just a reality check, not a change in behavior. But if I stop walking down the hall because I keep hearing my name, that's a change in behavior. If I withdraw from people, that's a change. Okay. If I shut the curtains because I think I'm being watched, that's a change. If I won't go out at night because I see shadows, that's a change.
Mm.
Does that help?
I have to say, I always get hung up on this point, Barbara, because the reality check part, always, because I look at it as like a change in behavior because it's often not like, I understand the case where it's like one time a person might ask, oh, did you hear that? But I notice sometimes a person may be doing more of that like throughout the day, sort of like it's increasing in terms of the number of times that they're doing the reality check. And I always grasp with like, what's the threshold of what we're saying change in behavior versus reality check?
Okay, so I want you to remember frequency never impacts the rating. It does impact the diagnosis, but you never alter your rating based on frequency. Never. Remember the criteria for establishing your rating. You're always focused on the what. What are they experiencing? How true to a percept is that? What do they make of what they're experiencing? What do they do differently because of what they're experiencing? Not the why. Never the why, never the frequency. That only comes into consideration when you're making the diagnosis. Look at it as two separate things. I rate it, if it were present in the past month, I rate it regardless of anything. But just because I rated it doesn't mean it's also going to be diagnosable. Keep those two things very, very separate. Now, one of the things, because I know a lot of you are engaged in research and clinical work, there is a difference in the frequency of CHR in those populations. In a mental health clinic, 20% of young people who present to the clinic will meet criteria for CHR. Okay, it is different when you are specifically recruiting for a study. But in a clinical setting, just so you have some idea of how prevalent or not this is, it's 20% of the population in the 12 to 25-year-old range will meet for CHR criteria. And so we really have to get that information out to people working in clinical settings because it is so underdiagnosed in the population.
My mind is blown by that. Remember, 20% in a general clinic.
In a general mental health clinic that serves people 12 to 25.
Oh my gosh.
Yeah.
Is there a paper that you can share that is?
Yep, it's right there.
Was it all wow, that's wild.
Yeah. Yeah. And you know what, Michelle, you are not alone in that. Everybody is like 20%. Are you kidding me? You know, nobody thinks it's that high in the clinical setting because it isn't recognized and it goes undiagnosed, unfortunately. Okay, so we have a couple of questions. I wasn't sure who was first. I apologize, but somebody just asked me.
Go ahead. You were ahead of me.
Thank you. Yeah, so for that, actually, our group recently read a paper from World Psychiatry. And it was like a paper published from Finland group. And then like, basically they looked at the conversion rate to either schizophrenia spectrum or bipolar spectrum. For the adolescents, I think it was just adolescents, like discharged from inpatient. And I remember that the conversion rate was like close to like almost like a 50%. Is that correct me if I'm wrong? And it was like shocking to like it was like just
it was very high in that particular study that you're referring to. You're correct. So back in the day when we first started doing this work, before we had evidence-based interventions for this population, the way that it broke out was 33% each, okay? 33% of the people who were found to be at clinical risk without any intervention went on to become psychotic. 33% didn't get worse, but they didn't get better. They just got stuck. And 33% remitted all on their own. Of course, it's no longer considered ethical not to treat this population. So we no longer just watch, we intervene. And now it was for a while, the conversion rate was also at 20%. But now with the onset of so many CHR clinics, I'm very happy to say that the conversion rate has been reduced to about 15%. So it's not where we want it to be, but it's certainly moving in the right direction. So I do know what study you're referring to, and it really was a higher conversion rate. And currently right now, I mean, I'm sure everyone is aware of the Naples studies that went on for years in the 9 sites across the United States and Canada. And we are now doing a long-term follow-up with all of those people that were in Naples 1, Naples 2, and Naples 3. So we are following people who are more than 5 years out from when they ended care. And we are trying to track their long-term conversion rates. Because as I said, The highest risk is those first 2 years, but we are definitely finding people who convert even after 5 or 10 years. So we're trying to get a much better handle on the overall conversion rates. And yes, Victoria.
Thank you, Barbara. I'm going back to the previous question about behavior change versus reality check. My question is for people who report like an emotional response change, if that's I get really irritable when it happens, it makes me irritated. Is that
Change, yeah.
that's sufficient to be a behavior change? Okay. Thank you. That was my question.
You're welcome. You're welcome. Okay, again, why are we doing this work? To prevent or delay or reduce the impact of psychosis, to reduce the psychosocial disability, absolutely to reduce the duration of untreated psychosis. Definitively, all the research shows the longer the dupe, the worse the prognosis. But the longer the prodrome, the worse the prognosis, okay? We want to reduce or limit behaviors or incidents that may stigmatize the person. We want to reduce their need for inpatient care. And the other things that we've learned from these 30 years of research is individuals, when they are identified early in the CHR phase, even if they do go on to become psychotic, if they were engaged in care at the CHR level, they have an increased likelihood to stay engaged in care, even if they become psychotic. So if you can engage them early, it's going to impact their prognosis, even if they do convert. And it's certainly, you know, let's be honest, once somebody's fully psychotic, they're probably very paranoid. And so they're not likely to be active participants in their treatment plan. They're not likely to develop a really solid therapeutic relationship. When we catch them in that CHR phase, they're aware, I'm changing, I'm different, something's going wrong. And they want help, they want answers. So they're much more likely to build a therapeutic relationship with you. They're much more likely to be an active participant in their treatment plan. Because they are, the probability of that treatment plan being effective is increased tremendously. Of course, it gives them rapid access to treatment if we're monitoring them at the CHR stage. As soon as they convert, if we're doing repeated evaluations, we'll reduce their DUP. And it has been demonstrated that if you treat people in a preventative way at the CHR level, there is a cost effectiveness. You know, unfortunately, when we let people become floridly psychotic for too long before we identify them, the costs to not only the mental health care system with the repeated hospitalizations, but to the police department, the ambulances, and all of those other things is greatly increased. Again, we want to reduce the symptoms and the disability associated with those symptoms. We want to improve their social, occupational, and educational functioning. We want to help them return to age-appropriate activities. And absolutely, we want to reduce the duration of the untreated psychosis. These are some of what I see as I'm consulting with people about the most common errors they make using the SIPs. Number one, they fail to set up expectations prior to conducting the assessment. This is why we require pre-screening. Number one, You want to establish the minimum eligibility. Are they the right age? Do they have the minimum IQ? Have they ever been treated for a fully psychotic disorder? So that you're not doing unnecessary assessments. But you also want to set the tone, especially if you're working with minors. You want to be very clear. Remember, this is a stress vulnerability disorder. Anything you can do to minimize the parent's stress and the patient's stress prior to the assessment is going to give you a more accurate assessment. So make sure you explain. I'm going to meet with the two of you for about 15 minutes, take some background information. But Johnny, I want you to know, then I'm going to ask mom to step out of the room, and it's just going to be you and me. And I want you to know, if that makes you a little uncomfortable, we'll make sure mom's right outside the door, and we can get her if you need her. But set that up first. Don't blindside that young person. If they're not prepared that they're going to be alone with you, it's going to skew your ratings. If you're doing it virtually, make sure you establish that that young person needs a private space to do the evaluation with you. And believe me, I've done many sips with the young person sitting in the bathroom in their house, because that's the only private room. But please set up those expectations ahead of time. Make sure you introduce the assessment properly. Remember, stress vulnerability. Having a psychiatric assessment is stressful for anybody, but it's twice as bad for this population. So you've got to let them know the questions I'm asking you aren't designed specifically for you. They're the same questions I ask everybody. So you're going to be able to relate to some of them, others not as much. It's okay. No right or wrong answers. I'm not here to label you or judge you. I'm just here to figure out if there's anything we can recommend to help you feel and do better. They need to hear that. It's critical. The other thing, as I said, is raters get hung up on the why. And you don't want to think about the why when you're making the rating. The why doesn't matter. What you're saying to yourself, I'm in P2. This is suspiciousness. Is this person endorsing a sign of suspiciousness present in the past month? If they are, you rate it regardless of anything. You only look at the why when you're making the diagnosis. Now, the only thing I will say to you, I have seen some people make an error. P2 is suspiciousness, right? But if somebody says to you, well, my dorm is in a really bad neighborhood, so if I were near my dorm, I would be watching my back. That's not suspiciousness. That's good judgment. That would be a 0 rating. So it has to be a yes to the true definition of the item. Okay? So make sure you're clear on what each of the 19 items represents. Okay? Yes, Michelle.
I think you partially answered that one, but I think on P2 is where I will most often see kind of context being important to determine whether it is paranoia or not. So, there are, so that's a place where a lot of, like the context of the culture that the person is in, the subculture, sort of thought. So this is where like things like, conspiracy theories that might be really common on the internet kind of thing that the person is like, well, it could be because I'm, and like everyone in their friend group believes it, or, a person of color who's being harassed by police on a regular basis. Like these are things that are real and I would not rate, but that is context. Does that make sense? Or
yes, absolutely. Because so let's talk about that for a minute. The example I always use is middle school. I mean, I got to tell you, since I've been doing this work, no doubt in my mind, middle school is the most vicious place on the face of the earth, okay? The kids are wicked to one another. And so you're really differentiating, is this a negative judgment of myself or is it suspiciousness? So if it's, you know, when I walk into the class and the popular kids are there, I think maybe they're making fun of my shirt or they're making fun of me. That's a negative judgment of self. That's not suspiciousness. That's a 2. Okay. But if I think they're, you know, they're out to trick me or con me, or that's the thread of paranoia. That is different than a negative judgment of self. If I say, well, you know, when I go to the movie theater, that's in a really bad neighborhood, so I'm going to be way more cautious. Again, that's good judgment, not suspiciousness. That's, you know, a difference. But context does matter. It definitely, definitely matters. So, especially in the case of trauma, you know, trauma definitely is going to impact your trust of people. In the case of trauma, if they are mistrustful and suspicious, you rate it, but you're not going to diagnose it because then you're going to better account for it by PTSD due to the trauma. So, you know, always in P2, you are always asking, does it generalize? Would you also feel that way in a safe neighborhood? Would you also feel that way, you know, around your friends or your family, you know? So context is important in P2.
Barbara, could you speak just a little bit either here or when we get some more questions about, you know, I find that question about the why, like how the person's accounting for it to influence, I guess, the rating when it comes to like level of conviction and their understanding when we're looking at, you know, when a person gives an explanation as to why they think this is happening, sometimes it then leads to hearing that it's actually due to maybe like a very paranoid reason or a delusional belief or even related
Would you
to
give me an example, Lauren?
um, so you know, I think everyone is at school. When I go to school, I think people are, you know, talking about me and and you know, I'm very worried about that. And so on the surface, that might look like the middle schooler who's kind of anxious, right? And concerned. But then if you ask why, they may say, well, you know, I think that's happening because people can hear my thoughts. I think people are
Okay,
talking about me.
so that's different, okay? That's not really the why. That's them endorsing another unusual thought. So then you're really rating, they think people can hear their thoughts, okay? So be careful. The why is, oh, you were sad, so that's why you had that, so I'm not going to rate it. That's the wrong thing to do.
I see different things because I do get hung up sometimes in when I think people are endorsing items and then the duplicative ratings. So I also find that comes up on P4 around then
All
like
the time, absolutely. And that's a tricky thing because I've had a lot of people say to me, well, you're double rating. You're not really double rating. You are rating different aspects of an experience on 2 different items. So, you know, if you know, the example I always give is that young girl who had the tactile illusion of a cold wave coming over her body. That has to be rated on P4. She tactily feels the cold wave. But when I said, what do you make of that? She said, well, I think it's the ghost of my dead grandmother. Well, that's an unusual idea. So now I've got to rate that on P1. So you're looking at different aspects of the same experience. That does matter, okay? But, I've had people, P4, yeah, I see shadows in all the time out of the corner of my eye. I'm always seeing shadows. What do you make of that? I don't know. Maybe it's the lighting in the room, or what does that tell you? That answers their level of conviction. It doesn't change the perceptual abnormality description. Okay, it's still a 3, but it addresses their conviction. They're trying to explain it away. If they're trying to come up with a reason. It was the lighting in the room, or, oh, maybe my cat ran by and I just didn't realize it. That lets you know they're not fully convinced in the reality of that experience. And that lets you know they're not psychotic. So that might give you informed information about another piece of the description. First, you focus on the description, then you go to the tenacity, the distress, and the interference.
Thank you, Barbara. I do find that on P4, sometimes when there's more like the shadows, maybe hearing things, footsteps, right, cabinets opening. I sometimes find that then on P2, there is an increased like hypervigilance and beginning maybe some concern, like, I don't know if people are kind of messing with me, or maybe it was just my family. It's kind of vague, but any thoughts about, at what point do we really consider that like a 3 rating in suspiciousness, when it's more like what I just described in response to really
Right. So if I'm in P4, I did P2, didn't pick up on anything. Now I'm in P4 and I hear that, I'm going to go back and redo P2. I'm going to separate it out. I'm not going to let it influence my P4 rating, but I am going to go back to P2 and say, let's talk about this a little bit. So you heard the footsteps, and then what did you think? And I'll make them walk me right through it. And you're right, very often with perceptual abnormalities. At first, it just starts out, wow, that was weird. What was that? Oh my God, there it is again. Why does that keep happening? And then their thought disorder kicks in and they start coming up with explanations. When their explanations are, oh, maybe it was the lighting, that's different. They're looking for a way to explain it away. But when they tip over to, it's somebody messing with me, then you've got to go back and rate that on the P2. Then the next most common is people really get confused with the better explained convention. Like I said, some people, as soon as they hear somebody's depressed, they think they're not CHR, and that is just so wrong. But the experience has to be as it would be described in the DSM-5 for, let's say, major depressive disorder with psychotic features. So if I hear a voice and I have major depression, you're going to ask, what if you woke up in a neutral mood? Would you still hear the voice? Because you're looking for, does this perceptual abnormality only occur in the context of a mood episode? And then you're going to look at, is it mood congruent? So the voice is always negative. You're useless. You're worthless. Why are you taking up space on the face of the earth? Okay. A classic example, so many people get this wrong. In P1, they'll talk about, I feel disconnected from myself. Everybody's got dissociation now. That's the big new symptom. Okay. And this and that. But when you dig, you realize they're in the middle of a panic attack when they're having that. If it's only occurring during a panic attack, that is better accounted for by panic disorder. So that you would want to determine. So remember, there's always two tests: temporal sequencing, which is very easy, but doesn't always give you the answer, and then the most characteristic test. So temporal sequencing is simply which came first. You know, if you're suspicious and you're a victim of rape, I have to determine, were you suspicious before the rape or only since the rape? You know, if it's only been since the rape, I don't have an answer, okay? Because it could be due to PTSD due to the rape. But if the suspiciousness predated the rape, it couldn't be causal. It may have made it worsen, but it didn't cause it. So in that case, PTSD and suspiciousness coexist. But if I can't answer by temporal sequencing, then I go to more characteristic. And then you look for, obviously, if this poor young person were a victim of rape, and now they're very suspicious of males and only males, then I'm going to better account for that by their PTSD due to the rape. But if they say to me, I wouldn't matter if it was my friend, my mother, a child, I wouldn't trust them. That's not most characteristic of PTSD due to a rape. In that case, they would exist comorbidly. So it really has to better account for the symptom you're seeing, not just that they have another comorbid diagnosis. Yes.
So it reminds me of like a couple of cases that we were sort of puzzling. So for this specific instruction, like the cases that we can think of, is like we tend to really get puzzled by patients with either autism spectrum or some level of intellectual disability, and yet, meet the criteria for exclusion. And then sort of like the item mainly came up was like a P4 actually. And yet just like, if you don't think about SIFs and then doing just a regular psychiatric interview, it feels like it's, it's related to level of that social and academic or, whatever other stressors that they are going through. And yet they are clearly endorsing it. So I was wondering if that is kind of an example that we can sort of apply.
Yes, you want to be careful. You don't want their stressors to make you better account for it. Okay, that's a psychodynamic process. You don't want to better account for it in that way. I will tell you the easiest way to distinguish ASD from CHR is onset. Okay, ASD usually onsets at a much younger age. Okay, the people we see that meet both ASD and CHR, they had their ASD symptoms pretty stably through their life. And then they hit puberty and new stuff starts. That's where you're going to see the comorbidity. Biggest difference. ASD is usually onset at an early age and pretty, with fluctuations, but pretty much throughout their life. CHR absolutely onsets during puberty.
Thank you. And the other part that tends to become challenging for assess that population, and I cannot say really population because our N is so small, but we had a couple of cases. The other challenging part was their report of a symptom, like for example P4. It's kind of not consistent. When we do assessment, they sort of change or it doesn't quite match with the collateral that we gather. So like that is another, but like we were wondering like how we handle that sort of a situation.
Yeah, you never want to change your rating based on collateral information unless it is an inpatient hospital record. So if it's an inpatient hospital record and it was documented during their hospital stay that they were exhibiting paranoia in the group or whatever, that you would take. But if it's a report of a parent or a teacher or someone else, you never change your rating. You always present the information to the patient to get their explanation of it, but you never alter your rating because of the collateral. And the reason for that is the SIPS is evaluating internal experiences. No one can know your internal experiences. They can observe your behavior and make assumptions about your internal experiences, but they can't know it. So you really need to hear it from the patient's own perspective. Okay. So, I mean, we value collateral information. We always think about it. We present it to the individual to get their perspective on it, but you never change your rating because of it.
What about, we do SIPS assessment and then psychiatric interview separate, like usually after that. There's a mismatch between these two assessments.
Then you present it to the patient. Can you help me understand this? Okay. I've had to do that many, many times. And it's amazing to me the explanations I get from the young people. I mean, it's probably been a while since you all took your SIPS training, but I always give the example of this young 10-year-old girl whose mother came into a SIPS in tears, crying to me. My mother had schizophrenia. So the child's grandmother had schizophrenia. And she said, now my child has schizophrenia. And I was like, what makes you think your child has schizophrenia? And she said to me very clearly, my daughter hears voices. And this young girl looked at her mother and was like, what are you talking about? I don't hear voices. And I said to the kid, just stop and think about this a minute. What could mom be seeing that might lead her to think that you're hearing voices? And ultimately, what this young girl explained to me is she was an only child, and they lived in a very rural area of Connecticut. She had no neighbors. Her parents both worked. When she came home from school, she was alone for 2 hours. And she said to me, I'm lonely. I invented an imaginary friend to keep me company. So maybe when mom walks in, she hears me laughing with my imaginary friend, and she thinks I hear voices. Well, that wasn't psychopathology, but had I rated it on the mother's presentation, I would have misdiagnosed that young girl. So you've got to really be careful with collateral. Now, the other thing, though, I will tell you about collateral. If you are rating something because you observe it, the patient isn't endorsing it. Remember, you always rate what they report and what you observe. I've done many SIPs where I'm asking the P2 questions and it's no, no, no. Meanwhile, throughout the interview, I'm writing, I'm taking my notes, and they're like, what are you writing, Dr. Walsh? What did you say about me? Did you say something bad? Doesn't matter that they answered no to all the questions. I'm observing them being guarded and suspicious with me. I have to rate it, but they're not aware of it. They're not going to be able to tell me when it onsetted. They're not going to be able to tell me how frequently it's occurring. Then I'm going to go back to the collateral person. I've seen it, so I know it exists. Now I'm going to ask the collateral person to help me establish the timeline. Yes, Zachary, I think you were next.
Thanks. I think I'm sorry if everybody else feels like they get this, but I'm not fully understanding. I think the third bullet point of considers the why when making a rating, because I'm probably like confusing like different like pieces of this. When you say we shouldn't consider the why when making a rating,
are you referring to their level of conviction?
No,
No.
why
Okay.
the symptom is happening.
Like the
Okay.
etiology of it, or like
Yeah,
what
yeah,
disorder
yeah.
to, okay.
You're
Okay.
not looking for a causal, okay?
Right.
You're looking for what is the experience? What do they make of it? What are they doing differently?
Mm-hmm.
Okay.
Okay.
So
That makes
too
sense.
many times people will say to me, oh, you know, they think that way in an unusual thought. They think that way because that's part of middle child syndrome. So I'm not going to rate it. Wrong thing to do. Okay.
Mm-hmm.
You're not looking for a causal. You're looking for the what. What is their experience? How true to the item is that? How true to a percept is that? And that's how you're determining your rating. The why comes in when you're determining the diagnosis.
Mm-hmm. Mm. I see. I see. So the key difference here is like rating versus diagnosis.
Absolutely.
Got it. Got
Two
it.
different sets of criteria. Yep. Somebody else had a question. I'm sorry. I didn't keep track. I think it might have been Tamara.
Yes, thank you. So Barbara, you answered this earlier, and I think I'm still kind of, I want some additional clarity on the research ratings. So for example, an example that was given before was if an individual has autism spectrum disorder, and let's say they're saying that they hear voices, they hear them frequently, they know it's of a man, and they could describe the voice. And then also it's been consistent since they were younger, and it's been very consistent throughout, and nothing has changed. So
You're gonna rate it a 4.
Still
They
rated a
hear
4.
a male voice, which is formed. They can distinguish between a male and female. They can hear the words. That's a 4. You're gonna rate it a 4. You're not going to alter your rating because it's consistent when it started, how frequently it happens. It is formed. It's a 4. Now, when you get to that 4th box, better explained, if you're going to say this onsetted very early in childhood is better accounted for by their ASD, then you're going to check likely ASD, and that's going to get you out of the diagnosing in the back pages. And again, that's why I said to you, what gets them out of the diagnosis is very important. It's not just that they didn't meet the diagnosis. Then you do care about the why. Why didn't they meet the diagnosis? Was it not frequent enough? Or was it that it's better accounted for? Because how you're going to work going forward in those two circumstances is very different.
Thank you. That's really helpful.
You're welcome.
I had one other question too, because you previously before you had mentioned when you would ask people to come back for a reassessment. I know you said like 1 month or 2 months if people endorse something that's kind of, it doesn't meet criteria yet. I was curious what your recommendation is for people that are using substances, because that happens a lot for us where people come in, they're using marijuana way too frequently. And then sometimes we get tripped up of when we say, hey, come back. In the DSM, I know it says, I think it says a month of detox or something like that. So I'm curious what your recommendation is of when you request that people come back.
So believe it or not, the criteria is the same for all 4 assessments, the SIPs, the mini SIPs, the psychs, and the CARMs. And it's very specific for all substances other than alcohol and marijuana. If the person's been 30 days clean of the substance and the symptoms still persist, you no longer better account for it by a substance-induced occurrence, okay? So if they come in for the SIPs and they haven't been clean 30 days, you're going to ask them, do you think you can make it 30 days clean of the substance and come back and reassess, okay? For marijuana and alcohol, it's very different. even if somebody smokes daily, okay, if the symptom occurs outside of that peak hour of intoxication, you're not going to discount it. So even if they're smoking every day and they went to bed at 11 o'clock last night, smoking all night, okay, and they wake up at 9 o'clock this morning and they have this symptom, that is not better accounted for by their marijuana, even if it's daily use. Okay, marijuana and alcohol, you only discount it if it's in the peak hour of intoxication.
It's kind of curious. Was there a reason why we sort of keep that way, decided to do that way?
I'm sorry, I couldn't hear you.
Was there any specific reason why we decided to do that way, rate that way for marijuana and
Yeah,
alcohol?
there were research studies done on it. And of course, this is nothing we would want to share with patients, but the literature on marijuana use is very contradictory, because there have been some studies that show the quality of the marijuana really makes a difference. If it's high THC, that really contributes to symptoms. But if it's a lower THC, higher CBD, it might actually be protective. So there's a lot of work that still needs to be done on it. But based on the research, all 4 assessments accepted the same conventions. Yes, Lauren.
Okay. I just want to go back to one of the points that you had made about collateral but specifically about inpatient records. So in our program, we often have access to a great deal of the past hospitalizations, and these are young people who are often going inpatient, not necessarily due to clear, let's say, psychotic symptoms, or something else has gone on, suicide attempts, self-harm, major depression, and when we're evaluating them, we often kind of have been using the means of asking about things that they may not have reported in order to try to get their own endorsement based on things that we've referenced from maybe the record. Where I think it's been challenging is related to some of the documentation and inpatient stays make it sometimes look like the person may have actually reached a 6 rating, and maybe they actually did during sort of peak moments throughout that hospitalization, but the person now is, 30 days, 60 days out from that inpatient stay. They may have been started on medications, and their recall of what actually happened during that stay, for whatever reason, is very different report. But on paper, the person, like we had one.
You go with the paper report. If it's a professional who documented it in their progress notes, in their med record during a hospital stay, that is the one time the collateral takes precedent. Okay, because you're right. In hindsight now, they're not going to remember exactly what they went through when they were inpatient. So you are going to take the progress notes that were documented, that are very clearly paranoid with their roommate, or, accuse their roommate of taking their shirt, any kind of documentation in that inpatient stay from a professional, you would override what the patient is reporting to you.
Is that like an update in terms of how, is that like a change in terms of practice, or has that always been the
That's
case?
always been.
Huh.
That's always been the case.
Yeah. No, it's challenging. I think we may have people that maybe were more pops, right? It's like this, it's really difficult in terms of, inpatient records. There's all types of professionals who are documenting, and sometimes, it's a couple lines that lead to a great deal of like inference about what actually happened. Like I'm thinking of one client who it was very brief, but it was, seeing what seemed like a shadowy figure that seemed like maybe carrying a knife. And so for that whole evening, like barricaded themselves in the inpatient room, covered everything.
Okay,
they
so
could.
you're bringing up a very good point, okay? Remember the POPs criteria. There's two different criteria. In the moment that that person had that experience, no matter how brief, if it resulted in dangerous or disorganized behavior, that's automatically psychotic. So if I think somebody's chasing me and I run into my room and I move all the furniture up and I barricade myself in, that's disorganized behavior. That is psychotic according to the DSM-5. Okay? Or if it results in dangerous behavior. In the moment, I hear the devil, and the devil tells me to get a knife and stab the next person that walks in the room. So I get the knife and I'm waiting. Dangerous behavior. Even if tomorrow I'm like, wow, that was stupid. What was I doing? It doesn't matter. In the moment, no matter how brief, if the experience resulted in dangerous or disorganized behavior, that is full-blown psychosis. If it doesn't result in dangerous or disorganized behavior, then you look for the frequency and the duration. But first determine if it resulted in dangerous or disorganized behavior.
Barbara, can I ask one other question that's a piggyback? Because I really get hung up on this with, there's such implications. As soon as we say, because of that brief disorganized behavior, right, that it's POPs, it's like they're no longer, in a CHR program. We start trying to now think about, a first episode program, which the first episode programs then say, what are you talking about? That was like a 10-minute, instant where they had a, lack of insight. Clinically, it has so many implications. I think that's why I get hung up on this. But we have had a number of clients with profound, like emotional kind of dysregulation, impulsivity for a number of reasons. And when there has been instances when getting very upset by things, and then maybe there being a shadow or getting paranoid or voices present, maybe on one or two occasions across many months, they will actually go get a knife, like a kitchen knife, and hold it and go looking around their house. And like the parents get involved and kind of calm them down. And in 10 minutes, back to saying, I overreacted, I'm okay, and have full insight back. But I've always got hung up
So a
about
shadow's never going to get them a 6. Probably never going to get them a 6.
the knife part, that I always wonder if the knife.
Right, but first you got to go by the description, Lauren.
Mhm.
Okay, and a shadow isn't a fully formed hallucination. Okay, so first go by your description. Now, if what you're saying to me is it was a P2, that they thought somebody was chasing them or out to get them, and it was a full conviction, that would probably be a harder call.
It was the specific, I should classify. This one was, got home from school, thought that they saw what was like a shadowy looking figure in the window, which they thought could have meant there's an intruder in the home. And then went through the whole hunt of the house with the knife in hand to try to see, in the case that person was actually in there, they needed to protect themselves.
Okay, so they weren't looking, they didn't take a knife to stab somebody. They were protecting themselves. That would not meet the criteria of dangerous or disorganized behavior. You got to be careful with self-harm too. Many emotionally dysregulated young people self-harm, and it has nothing to do with being psychotic. So it's very different. I hear a voice and the voice tells me to stab myself, that's psychotic, and I act on it, that's psychotic. I'm going to cut myself, you know, for other reasons, that's not necessarily psychotic. So you have to be careful there.
Okay, thank you.
Michelle.
Thanks. It was a good discussion. So I just wanted to follow up on to make sure I'm understanding correctly about when you can use collateral information. So if you have a documented hospital record that describes fully psychotic behavior, they meet POPs. What about if you have a hospital record that documents CHR level behavior, but when you ask the client, they say no? In that case, I'm thinking you really can't go with that. You need the client to tell you the symptoms, but I wanted to make sure I understand that.
Yeah, you are correct.
Okay.
You are correct.
Okay,
Yeah.
making sure. So it's really the collateral info helps you diagnose POPs, but not CHR.
Exactly.
Yes.
And collateral gives you a place to question the individual.
Exactly.
Don't
Okay.
ever want to ignore it. You always want to present it and see, you know, what you can determine from it. And again, then if you observe it or the person says, oh yeah, that does happen, then you can use the collateral to help you establish the timeline.
Thanks.
Now, I will, and I don't want to confuse people. Sometimes I think when I share too much information, I do confuse people, but I have to be honest. I have had many young people who presented to the ED saying, I heard a voice, I heard a voice. And in the ED, they just gave them psychosis NOS and moved them along. I don't necessarily take that as psychosis. I will query that one because let's be honest, in an ED setting, a psychiatrist doesn't have the time. Look at how we're talking about how hard it is to split all these hairs. You know that isn't happening in the ED. They just don't have the time or the resources to do that. So with that ED only, very quick psychosis NOS, I will still conduct the SIPs and make my own determination.
I agree. And just for our, Massachusetts colleagues, I do think it happens not super infrequently that we will have folks that have been told they have schizophrenia. When you actually do the SIPs, it turns out they don't. So, yeah.
I've had young people come into me and they say, yeah, I was told I have schizophrenia. And they clearly have a perceptual abnormality, maybe at a 5, but they don't have any delusions. They don't have disorganized communication. It doesn't meet the DSM criteria, but some clinician heard voices and said, you have schizophrenia. So you've got to be careful of that. I mean, none of us want to judge our colleagues and say they made errors, but you do have to be fair in your assessment.
And just on the piggyback of just the Massachusetts piece, Michelle, this is reminding me of a larger conversation we had about records recently and like empath and, the screening when someone calls like a parent, right? They're not even privy to the details of what necessarily occurred in an inpatient stay. They're just sort of like, they're just playing what they can. And so I think it just, with this information now about when things are so explicitly maybe documented already in inpatient record, in terms of screening, if we get to a place where there's more of like, if someone's already able to decipher from an inpatient stay that this is like POPs, I think that might change the course of who makes it to even these SIPS evaluations. But just putting it out there.
The other thing I want to talk about with the Better Explained Convention, as I said, I've done over 3,500 SIPs to this day. The most difficult ones for me, making the differential diagnosis, are extreme cases of OCD. There, obsessive thoughts can be so borderline delusional to me that I really have a hard time. And what what you need to follow is, when in doubt, when it isn't clear cut to you, is this coexisting or is one better explaining? Rely on your ethics. A, would you be doing any harm to this individual if you said they were at risk? Or would you be keeping them from a better specialized care that would treat them better? And if you're not going to do harm and you're not preventing them from getting better care, err on the side of inclusion. You may find out this, it's happened. I've made the call. It is OCD and CHR. I take them into our clinic. 2 months later, I'm like, nope, I was wrong. This is OCD. And then I send them to the OCD clinic. But I've also erred the other way. I've said, no, this is due to OCD, not CHR. I send them 2 blocks down the street to the OCD clinic. And in 2 months, they're calling me and saying, Barbara, no, this isn't OCD, it's CHR. There's going to be times where we get it wrong, but always apply your ethic. Will I be doing any harm? So you want to apply that. When you're unclear, that's not a person you would ever want to have prescribed antipsychotic medication. You want to wait and let it play out a little more to see.
Barbara, with that example of a person who, let's say we have this where we've carried someone for a while and then update kind of our diagnostic understanding. Is it that then they might just be kind of saying APSS in remission, for example, like in full remission?
In remission is different. In remission would not be that the better explained question wasn't clear. Because remember, in remission, you can't have any P items in the 3 to 5 range. Partial remission would be if it's 6 months or less. Full remission, it would have to be greater than 6 months. So that's a different than when you're not clear on the better explained.
I think where I'm getting hung up is when a client had came in, right, and we initially found that they were rating to meet criteria. At that time, we did not necessarily think it was due to, let's say, panic disorder. And so they were rated, we said it's APSS, like progressive, right? And then 6 months later.
That's not rated, that's diagnosed.
I mean,
Make
diagnosed.
sure they're separate, okay? Because your rating is different than your diagnosis.
Okay. In that case, I think they both would have a rating and also a diagnosis, because at that time we didn't find that what they were reporting was attributable to any other diagnosis. We believed it to be at that time due to a psychosis risk syndrome. And so then months later, we followed them in care and now have updated diagnostic impressions where we say, we don't actually think this person, it was ever really a psychosis risk syndrome. It was actually, insert here, panic disorder.
Then you just acknowledge you gave them the wrong diagnosis. That's not remission because it never did meet criteria. Okay, you've just got to say it was a wrong diagnosis. Okay, and that does happen because we know the prodrome is fluid and we don't always have all the information. But you want to be very careful because remission, they definitely met the syndrome, but it's no longer in the risk. That's a different risk than someone who never really met CHR. So you want to be very clear when you're correcting yourself. Yes, Michelle.
I will make one quick note on that because I do see this happen clinically at Cedar for sure. Is sometimes we have someone who really did meet criteria, like they met for CHR, and then after like 6 months of treatment, they're no longer meeting for CHR. And sometimes our psychiatrist will say, oh, it turns out they weren't CHR, they were depression, because we treated the depression and now they're better. I disagree with that. I think that's a problem in the field that sort of happens, is people think it wasn't CHR because it got better. Because there's a little bit
Again,
of
it doesn't matter, they're depressed. You're absolutely right, Michelle. That's the wrong way to do it. The right way is, okay, at baseline, we said they met a 4 on P2, and that's what qualified them for CHR. With the new information we have, we now realize that that P2 symptom came from a traumatic event, and it should have been better accounted for at that time by that traumatic event. That's when you made the error, not they got better, because they do get better. We know they remit. Okay, we know this. 33% will remit with no intervention. We know they're going to remit. You know, this is a risk factor. Again, think about something in your physical health. You go to your physician, you have your blood drawn, you have high cholesterol. Your physician recognizes that's a risk factor for developing heart disease. Is it heart disease? No. Does every single person who has an elevated level of cholesterol develop heart disease? No. But it is enough of a risk factor that your physician is going to start you in a preventative program. Now, you always start with the least invasive form of care, diet and exercise. If that doesn't work, maybe some natural substances, omega-3 to lower your cholesterol. If that doesn't work, as a last resort, statins, okay? It's preventative, least invasive, work your way up, okay? If the prevention works, that doesn't mean you didn't have high cholesterol. You did have it, but we prevented it, which is our goal. We prevented it from getting something worse. And that's what happens. I mean, in our outpatient clinic, the majority of our patients do remit with evidence-based care. That doesn't mean they weren't CHR, they were, but the treatment worked and it prevented it from becoming a problem. So very different cases.
Barbara, can I ask just about the scoring sheet for this case where we look back and we say this person never actually met criteria for psychosis risk syndrome, they were misdiagnosed? Because my concern is when you just follow the tree and it says, did this person ever meet for, you know, a score or a rating of 3 to 5, and you kind of make your way down, it brings you to like in remission. And I understand if the person never had the condition, how can they be in remission? But what would you recommend in terms of like our documentation or our way on that follow-up?
No, it's going to be the second question. Was the item rated 3 to 5 ever not better explained by a DSM disorder? You're going to have to check no there, and that will show that it never met CHR.
Okay.
The other common error that happens is people just take way too long with their SIPs. And if your SIPs is taking 2 hours or more, you are absolutely introducing confounds, rater fatigue and interviewer fatigue. And what I always encourage people, if your SIPs are taking too long, please contact me. I typically can troubleshoot it very quickly and figure out why the assessment's taking too long. Because, and I don't mean the whole process, you doing the GAF, the schizotypal, the diagnosing. I mean, the actual interview portion shouldn't go more than 2 hours.
Barbara, would you be willing to share what like the most common reasons are that you find? Are people over querying?
Absolutely. So I think one of the things that people do wrong well, a couple of things. One is they use more than the 7 follow-up questions. If you use the 7 follow-up questions, you are going to get every bit of detail you need to make a good rating and a good diagnosis. When you over query, you're just prolonging things unnecessarily. And let's be honest, we all have a natural curiosity. When we hear about these things, we want to dig. But this isn't a general mental health assessment. This is a risk assessment. So you are only gathering the information to determine the risk, not to make every single diagnosis in the DSM-5. And that's really critical. The other mistake that people make a lot of the times is, you know, Victoria, in the negative, the general, and the disorganized, you don't need all that detail. You can't diagnose. And I'll hear people doing a SIPS. When did that start? How often is it? And I'm like, what do you care? It doesn't matter, you know? And so they forget that it's different for those other 3 domains than it is for the positive symptoms. So that's the other thing that I see go wrong a lot of the time, you know?
That's helpful.
Other thing is, the more you know how to do the SIPs, there's going to be steps that you eliminate. And I'll give you an example. So I'm in P1, okay? And very clearly, the person is endorsing believing in mind reading at a 3. It onsetted 2 months ago. It happens twice a week. I know from that symptom, they've met CHR. They're at a 3. It began within the last year, and it's happening at least once a week. Now, if I go on to predicting the future, and they say yes, and I'll say how so, and they give me an answer, if it doesn't trump the 3, if it's not a higher rating than a 3, I'm not asking the follow-up questions. It doesn't matter. It only matters if the next symptom might increase the rating. But if it's the same or less, I don't need all that detail. So again, the more expert you are at doing the SIPs, you know when you have to dig and when you don't. If I'm already there, you know, I've heard a million SIPs. The patient is so clear. Yeah, I hear noise. Okay, what does that noise sound like? I don't know, kind of like static. Static is unformed. That's a 3 rating, okay? Do you do anything differently when that happens? Yeah, I put my headphones on. I don't now have to ask you if it bothers you. Interference is occurring. I've documented that. I don't care if it bothers you. It's not going to change my rating. So the more you understand the differentials in making ratings, you know when you do or don't have to probe more. And that narrows the length of your assessment tremendously, especially in P1, because there's so much in P1.
Mhm. Thank you. That's really helpful.
Yeah.
I think the over querying gets tough when we suspect there might be a better accounted for diagnosis, and then I find myself trying to do a mini skid in that moment to see, like, do they actually meet criteria for PTSD? Is that better explaining this? Or and I don't know how you address that, because that's going to make the SIPs longer, but it's also important for us to know if it is better explained. Does that make sense?
It absolutely makes sense, Victoria. And I'll tell you what I do when I'm training people in our clinic who are shadowing me. I make them sit down with their DSM-5, and they make a 3x5 literal card. Okay, MDD with psychotic features. These are the 5 symptoms I'm looking for. Okay, bipolar disorder with psychotic features. This is what I'm looking for. PTSD, this is what I'm looking for. When you suspect it, you pull out the card and you just hit that. Because if you're just digging in general, you are going to dig long and hard because you want to be sure. And so ground yourself. What are the most characteristic symptoms that I need to document that diagnosis? And it'll keep you on track a little bit. It is going to elongate when you're doing that differential. Honestly, it is going to elongate the SIPs a bit, but you can manage it, you know?
That's helpful. Thank you.
And these three things, I don't care how long you've been doing a SIPS, you must always have these three things in front of you when you're conducting the SIPS. This is your Bible. This is your roadmap. These are the things that are going to ensure that you are accurate. Remember, we have kappa of 0.89. That's incredible, but it's based on all of this being put in place. Okay, so your cheat sheet is divided into 3 sections. The first part of the cheat sheet is the process, and it really grounds you. How do I do the overview? How do I ask the number bolded questions? What if they say yes? You know, exactly what you have to walk through. Another thing that happens, people are rating a P item a 0, 1, or 2, and they're querying about the onset, the date of worsening, the frequency. You never record that for a 0, 1, or 2. That only occurs, you can't have an onset date for a 0, 1, or 2. Because an onset date is the date it first met a 3. It's not the date it first ever happened. Excuse me, I'm sorry. Yes, Michelle.
I just want to make sure, because I think that what you said about not querying the lesser ratings, like 0, 1, and 2, I know, but like, let's say you have a 4, like someone hears voices. I just want to make sure I get this right, because I think this is contributing to SIPs taking too long in our center. So if someone has voices that are impacting behavior, right, clearly distinct, they, you know, voice quality is impacting behavior, bothering them, let's say that's a 4, right? No, it's not real. But then they also see shadows that don't bother them. Then you don't really need to ask about onset and, you know, like you don't have to ask a lot of questions about the shadows. Is that correct?
That's correct. Now, the only thing would be, Michelle, if it were a 4, but it onsetted longer than a year ago,
Right.
then I would query the onset date on a 3 rating, because that might make a difference between whether it was progression or persistent.
Got it.
Does
But you
that make
probably need to
sense?
say, like, you know, like if you're like, you know, how many times a week do you see the shadows? I don't know, like a few times a month. And like, does it bother you? No, like you wouldn't have to spend like a lot of time saying, well, let's think about it. Does it happen every day? You know, like that kind of thing. Right?
Exactly. You know, I've heard people, and I mean, I train people to do this. You know, if they're not good about the onset date, who was your teacher last year? Who was your teacher this year? That takes time. I don't want you doing that if you don't need it. You know what I mean? It's just artificially elongating the steps for no reason.
Yeah.
You
I think
know?
that comes up a lot because I'll see like vignettes that have like this thing started this time, bothers them, this thing. And like some of the things are not really all that relevant. And I think that really contributes to the
Yeah.
rating, the whole thing.
I think you're so right. And that's what I meant. The more you do the SIPs, you know, what am I looking for? What's the threshold I need? How do I get a solid diagnosis? Once you're there, you don't got to keep pounding what you already know. You know, like I said, the only time that would be different, I have had people who had a 4 symptom in P1 that started 2 years ago, but then they have a different symptom in P1 that's a 3, but it onsetted more recently. And I want to capture that because that puts them back to progression. So that's the only kind of exception, I would say.
Thanks.
Yeah. So this is the first half of your cheat sheet, which helps you stay focused on the process. This is the rating, okay? And again, always remember, the criteria for making a rating is totally different than the criteria for making a diagnosis. And even the most experienced SIPS assessors get this wrong. They blur rating and diagnosing. You have to view them as two very separate things. And then this is what you need for diagnosing. And believe it or not, one of the errors that I do see, so you can't be, if you've ever been fully psychotic, you can't be pre-psychotic. You can't go backwards, okay? But if you've never been psychotic, you can be BIPS, APS, and GRD at the same time. But you can't be APS, progression, persistent, and remission at the same time. Those conditions trump one another. So progression trumps persistence, trumps partial remission, trumps full remission. You can only meet one condition for APS. You can only meet one condition for BIPS, but they don't have to be the same condition. So you could be BIPS, partial remission, and be APS progression. It would be on separate symptoms, but you could be. And then the other thing you have in front of you always is your GRD decision tree. Because I'll tell you right now, this is the quickest way to save time in a SIPS. If there's no family history and there's no schizotypal, you don't got to do both GAFs and waste all that time, because the GAF is only to help you determine GRD. It is not a clinical assessment. It is never anything you would share in their medical record or with the patient or with the family. So if there's no family history and there's no schizotypal, you're not doing both the GAFs. Gonna save you a ton of time, okay? Likewise, if there's a family history, you don't need to do the checklist because you've already got the genetic vulnerability. Genetic vulnerability is either family history or schizotypal, doesn't have to be both. So if there's family history, you're never doing the schizotypal. And then your third sheet are the 7 questions. And these are really your roadmap to making that accurate rating and diagnosis. Does it ever seem to you like you get confused between what's real and imaginary? Yeah, Dr. Walsh, that happens to me. How so? Could you tell me a little bit more about it? Well, you know, when I'm in class, I get bored. And when I'm bored, I daydream. And in my daydream, I have a conversation with my friend. And then when I leave the class and I see the friend, I don't know for a minute. Did I have that conversation or did I just daydream it? Okay, and what do you make of that when it happens? Well, I'm just a little bit confused, but then I figure it out. Do you do anything differently because of it? No, like I said, I'm just a little confused for a minute. Do you remember when you first noticed that happening? How many times has it happened in the past month? And when it happens, how long does it last? 7 questions. I got every bit of information I need. I don't need to probe anymore. That's going to give me my answer.
Barbara, what would be your answer? I'm just curious, what rating would you have given in that vignette? Like,
of the person who gets confused when they're daydreaming, that would be a 3.
okay.
Okay. So anyway, that's just what I wanted to share, kind of from, you know, consulting with people and, you know, helping them problem solve what they got wrong in their SIPs. Those are kind of the lessons I've learned, you know, where people struggle the most. But I mean, I'm more than happy to answer any other questions that you have about things that you've encountered doing the SIPs.
I have a few, Barbara, but I want to make sure other people have a chance first, so just want to flag I have some.
Yeah, one thing I can ask you, I think this might overlap with Lauren's as well, might be a little bit about follow-up SIPs evaluations and a little more about how that goes. I think there continues to be a lot of confusion that folks have. We've definitely changed our practice since the SIPs training that we had with you about a year ago. But yes, procedures on the follow-up, you know, evaluations would be great to go over.
Sure, absolutely. So the convention is, if you haven't seen the person in 12 consecutive months, you're only doing the SOPs. You're not repeating the SIPs. And the SIPs is only at baseline, or if you haven't seen the person for 12 consecutive months. When you're doing it as a SOPs, you are not asking all the number bolded questions over again. You're not doing the overview. You're going to ask briefly, any major changes since I saw you, since we did this last together, okay? And then you're going to say you're going to go to the rating rationale portion of your SIPs. You're going to say, the last time I saw you, you reported feeling watched. It had started in September. It was happening twice a week. You weren't doing anything differently because of it. How is that today? Is it better? Is it worse? Has it changed in any way? And you go through and ask them everything that they endorsed last time. Because in retrospect, people forget, oh, did I really tell you that? I don't even remember that happening now. So you always have to ground them in what they reported to you. And then at the end of each P item, you're going to say, any new symptoms like this developed? Because very often what will happen in P1 especially, you know, at baseline, they endorsed, you know, thinking people could hear their thoughts, okay? Now, at my 3-month follow-up, they're endorsing that they think they can predict the future. They didn't have that when I did the baseline, so now I have to capture the new onset of symptom. So the last question you always ask, has anything new like this developed since we last did that assessment? And then you are making the rating based on what their experiences are today. Because remember, your rating is always based on what's present in the past month. And that's something I forgot to mention earlier. If you are doing the SIPs, if you're breaking it up, you always must do the 5 P items in the same sitting. You can't do the P items on different days. If you can't get through all 5 Ps, you've got to start over, okay? Because that 30-day period is very critical to your rating.
Barbara, just to piggyback on, you know, that question about follow-ups, it sounds like in some way we're hoping that the client is going to be able to identify what would be new or what would be like a symptom for them, based on like that very general question. And so, you know, like you asked what that was already endorsed, right? That helps ground them. But then I'm just thinking of how, how many different experiences may happen in the fluidity of like a prodrome, and the general question of like, has anything changed? You know, and not getting into the specific questions again of like, can you predict the future? And do you have any thoughts about?
So has anything changed is in relation to the specific thing they previously endorsed. When you're asking, has anything new like this developed? I always give examples like, do you feel mistrustful? Do you feel watched? Do you feel people are intending to harm you? So, you know, I will, you know, do you think people can read your minds or you can predict the future? I'll give them examples. I won't go through every single question, but when I'm throwing out there anything new like this, I kind of define the this for them.
I see, and that's at the end of each P.
Each P, yes. And again, just so you know, you can do the SOPs as frequently as once a week, okay? It's recommended that if you're working with someone, you do it at least every 6 months. But you can't, like in medication treatment studies, we do it weekly. You know, in some other studies, we do it monthly. In our treatment protocol, we do it every 3 months. So you can vary how often you do it, or if you're treating someone and you're in a therapy session and they're talking about something and you're like, wait a minute, this sounds like it's worsening, I'll just stop and do that item right then and there. So, you know, as an ongoing treatment protocol, you can pick and choose which P item you need to do with them.
Barbara, I'm curious, what is the rationale that you provide people with in terms of wanting to redo the SOPs on the spot? Because I find that sometimes I will ask my clients, hey, you know, maybe it's a good time to reassess some of these symptoms or what's going on. And sometimes they go, no, I'm good. We don't really need to spend time on that. Let's keep talking or let's do something else. So I find.
So I don't make it appear like a formal, I'm doing the SOPs again. If I'm in a therapy session with somebody and they're talking about an experience that happened, I'll just go into, how so? Tell me more about that. And then, you know, when do you remember it changing in that way? And how many times has that happened since I saw you last? So it's more conversational, less like a formal assessment.
Thank you.
But getting the same information.
Barbara, when you do the 12 months, like let's say you have someone come back in, or even they're an active patient, but it has been 12 months that's passed. Would you just speak to what it would look like to administer the full SIPs again? Like, for example, if we had like
Sure.
full staff.
Yeah. So the first thing, obviously, with the overview, you don't have to go back, tell me about the pregnancy. You know, you've already captured that. You're going to say, okay, I last did this with you on January of last year. Tell me what's changed in your life now. Have you changed schools? Have you changed relationships? Have you changed your living circle? You know, just get the update. Have you been hospitalized? Have you been ill? Did you have a head injury? You know, anything that might have changed since that in that year. And, you know, I will ask, since last year, did any of your family members get newly diagnosed with a mental health disorder? Okay. And then I'll transition into the, you know, the 19 items.
In terms of a history of POPs, like if there is a better explanation that can explain why that happened, like I'm more thinking about like substance-induced psychosis, for example, like a stimulant-induced. Do we still have to exclude the possibility of a CHR?
If they're psychotic, you don't have to look at CHR, because an individual cannot be psychotic and pre-psychotic at the same time, regardless of what caused the psychosis. So whether it was a postpartum psychotic episode, whether it was a substance-induced episode, it doesn't matter. If you ever cross the threshold to full-blown psychosis, never again can you be CHR. because that's pre-psychotic and you can't go backwards. Even if they're no longer actively psychotic, that would be residual psychosis. It would never revert back to pre-psychosis.
Barbara, what if that was in the context of, I just want to be clear, that was if it was clearly substance induced and that they had they had full-blown psychotic symptoms, and at that time we said they're psychotic because of the substance, and then are we saying we can never they were psychotic so they never can be pre-psychotic, but what if it was substance induced?
Doesn't matter. They were psychotic. They crossed the threshold, Lauren. You can't go backwards. Okay, that trigger in your brain's already occurred. You got to that psychotic level of intensity. You can't now be pre-psychotic. That doesn't mean you can't in the future meet a different DSM diagnosis for psychosis, but you can never be pre-psychotic.
So like this makes me think of major depression with psychotic features when it's like quite severe and so could you speak to that if they already had been psychotic in the context of major
Then
depression?
you wouldn't be doing a SIPS, you would do a SCID. If someone's already been fully psychotic, you should not be doing the SIPS.
I think it's like we get these referrals for, it's only when we do the SIPS that then we realize that that they had reached, let's say, a psychotic level threshold in the context of severe major depression. So we kind of learn
Then you
that.
would move into a SCID. Then you would stop the SIPS and move into the SCID. Okay, the SIPS is never, ever going to give you the DSM diagnosis of psychosis, of a specific psychotic disorder. It's only going to tell you they were psychotic. So you always follow it up with a SCID if they're psychotic.
So that person would no longer be appropriate to be re-referred at some point to be evaluated for a CHR possible status if that MDD with psychotic features?
Never. If they've been psychotic, they can never go back to CHR, ever. There's no point in doing that evaluation. Yes, Zachary.
Going back to the little bit where we were talking about follow-up assessments, and you were saying how like in some studies people can do these weekly even or every few months or something. When you're doing these weekly SOPS interviews, is the timeline that you're evaluating still the prior month?
Very
or
good
is it just the
question.
past week or something else? Yeah.
Very good question, Zachary. I'm sorry I didn't address that since I saw you last.
Okay, great. Because sometimes in our setting we'll have somebody get the full SIPS for the first time, and then after a few weeks or something they'll join another study, but we kind of want to update the SIPS, and so we want to we're thinking about to what extent what's the timeline here. So that's helpful.
Since we did this last. Yeah, absolutely. Yes, Victoria.
Sorry to keep harping on this. I'm having a hard time with.
No, please. That's what this is about. Okay. This is all very complicated.
Thank you. So if someone has a psychotic experience actively, let's say, under the influence of a hallucinogen, like they took shrooms, they heard voices, they saw things that were fully formed, etc., they can never then be considered CHR after having that experience, even though it was while they were acutely intoxicated with a hallucinogenic substance.
Correct.
Okay. Okay.
Again,
good to know.
They could develop another type of psychotic disorder, but they can't ever go back to being at risk of becoming psychotic because they already were psychotic. It's residual. It's still dormant. It's there. It's just not active.
Thank you.
Again,
case of
and I know
hallucinogen.
it's hard because, again, this is where you're combining the why with the what. Okay, it doesn't matter why they were psychotic. What matters is they were psychotic. And so you've got to try and tweak your brain a little bit to recognize that.
I
So
think with the case of hallucinogens in particular, it's a little hard to understand. I mean, just a little, it's confusing. There's lots of things to consider, because in the when with those substances, that's like exactly the effects you would expect them to have in some cases, like people reading your mind or people seeing things, if they're taking a high enough dose, that would happen to probably anybody. So is that, and I mean, you
But
could you
it
could you could
doesn't
argue like that's
happen
not.
to everybody. And that's exactly it. There's something in you that made you vulnerable, even with the substance, to have that experience, and you cross that threshold. And again, it doesn't mean that it wasn't due to the drug. It was due to the drug, but you crossed the threshold with it. And so you can't go backwards. It can remit, and the clock can start again, but you can't undo it.
Barbara, I was wondering if you could still provide some clarity on bipolar disorder. We've had clients in our clinic that have come through. They've been diagnosed with bipolar disorder already, or we noticed that that's a diagnosis. And my clinic's kind of been split on if that is a rule out for people to also have clinical high risk for psychosis, or if it's something that they could still be at risk for bipolar disorder with psychotic features.
They can, okay? It's a little bit counterindicated because when you have bipolar disorder, you are automatically at higher risk of developing a psychotic disorder just by the fact that you have bipolar disorder. So some people would argue, why do the SIPs? We already know they're at higher risk of becoming psychotic, okay? But you can have bipolar disorder without psychotic features. And in that case, that's not a psychotic disorder. So now you're evaluating, are they at risk of becoming psychotic? And like I said, some people would argue, well, they're already at risk because they have bipolar. But other people would say, but I want to know if there are more signs there that are indicating this is more likely to become bipolar with psychotic features.
I'm getting a little bit off track about that, but I recently had a kind of interesting discussion that in terms of that diagnosis between bipolar disorder spectrum and schizophrenia spectrum disorders, schizophrenia spectrum disorder diagnosis basically triumph over bipolar diagnosis. So they cannot coexist. So if it becomes kind of situation, we have to choose one or the other. But we see both existing kind of in a very separate way. Then we have to choose, we have to go with the schizophrenia spectrum diagnosis.
Yeah, that would again not be determined by the SIPs. That would be determined by the SCID. But yes, you're right. Schizophrenia trumps bipolar with psychotic features. You're absolutely correct. Yeah. Yes, Victoria.
Thank you, Barbara. I wanted to go back. I was looking at my notes. I think you said full SIPs only at baseline. And then at
Or
12
if you haven't seen them for 12 consecutive months. Yeah. Then
So
you go
then,
back to the SIPs, but you alter the overview section, just update me from when we did the original SIPs. You don't have to go back to the pregnancy.
right. But the altering is only for that. Everything else about doing a full SIPs, you're reading the bolded questions word by word, etc. That's all.
You're back to that. Yep.
Got it. Thank you.
And obviously, as we all know, the SIPs takes much longer than when you're doing just a SOPS as a repeated measure. That's so much shorter. And I know technically this isn't the right thing for me to tell you, but in the real world, out in the trenches, you know, when I'm doing the SOPS repeated measure for somebody I have in treatment, and I have concerns of something I'm hearing in the therapy sessions that I think is, I'll only do the positive symptoms. I don't do the general, the disorganized and all that again, you know, because I'm specifically looking for, you know, I probably am suspecting they may have converted. So I'm only going to make that diagnosis based on the positive symptoms. You know, the other ones are when you haven't made a diagnosis and you don't want to miss those people presenting with the negative symptoms first.
Hey, Barbara, I have a
Mhm.
quick question.
Sure.
It's kind of a complicated question. First off, thank you for leading this training. Really appreciate it. Second
Sure.
off, I was wondering if you had any personal experience conducting SIPS assessments for people who are kind of like concomitantly struggling with their religious beliefs as well as beliefs about their sexual orientation and maybe like gender identity. I imagine when like assessing for P1, for example, if someone, let's say, is like a like devout Catholic or identifies as that, or maybe like like a devout Protestant, but also is like maybe identifies their sexual orientation to be like homosexual or asexual, as well as maybe like conforming to a non-binary identity. It seems like you could kind of have a situation when assessing them using the SIPs on P1 where like their sexual orientation and gender identity is interfering and distressing, and also their religious beliefs are interfering and distressing. I don't know if you've had any experience
Lots
kind
of
of in this
experience.
context.
So in the last 5 years, the number, not just at Prime, but across the 9 sites in the Naples study, the increase in individuals identifying as trans or non-binary has spiked tremendously. And, you know, you want to keep that in context because in and of itself, that's not a disorder, but it is a life stressor. Anytime we're, you know, a little different than the norm, it increases our stress level. So you have to take that part of it into consideration. Is the way that they identify causing them an increased stress in their life? And does that result in a symptom that would be a CHR symptom? The gender identity is not the symptom. It's whether being stressed by having that issue in their life causes a different symptom that might be considered CHR. And whenever anything is subcultural, you never rate it higher than a 2. Okay. And anything can be a subculture. Certainly, it could be your religion. Okay. But it could be your family. It could be your ethnicity. It could be your sports team. You know, there are a lot of subcultures. And if it is within a person's subculture, you're never going to rate it higher than a 2. But you always want to query, Joey, do they generalize it? Because it could have started out as a subcultural belief, but maybe now they're generalizing it to other circumstances. And that you would want to capture. The other thing I want to caution you, it's different if something is your subcultural belief, then you have an unusual thought. You get on the internet, you search wide and far to find somebody else who shares your idea. That's not a subcultural belief. That's you looking for someone to share your belief. That's different. Okay. So, you know, but subcultural never ever go higher than a 2. And there's a wonderful book. I can look for it and I'll show you the link, but it's out of Harvard. It was authored out of Harvard and it's on subcultures. And each chapter in the book is written by a different expert who talks about subcultural beliefs in various groups and how they can lead to, you know, how they present differently for CHR or psychosis, but also things in different subcultures that might actually be self-protective in keeping them from developing that. So I'll put that up so you can see the thing. Yes,
Thank you.
Kira, you're welcome.
Thanks, Barbara. To the sort of subculture discussion, I feel like especially this year, I've had a lot of young people on P1 talking about a glitch in the matrix and sort of like expanded beliefs and views that relate to like kind of questions about whether they exist, whether the world is real, if everything's a simulation. And I guess I'm kind of curious if you've encountered this and sort of how you've parsed that apart from like what my impression is that this is kind of like a subculture among many young people, and how to kind of differentiate where that becomes something more pathological versus normative developmentally.
Yeah, again, you know, what do they make of the fact that they think they don't exist? Is it a philosophical discussion? How do we really know whether we exist? You know, something like that. Or is it, you know, I could be in somebody's dream. That would be psychopathology. Or this is a simulation and I don't really exist. You know, I'm not real. I'm not part of this world. That would not be subcultural.
Okay, that's helpful. I think something or a gray area that I found myself in is when a young person has talked about like wondering if maybe they're part of a video game, but they also wonder if everything is a simulation and it's not necessarily specific to them and their experience, but it's something that's more generalized to like, you know, is this something that's affecting humanity? Like, are we all part of the video game?
Yeah. And again, so they have that thought. So now what you have to determine is that belief distressing or interfering? Because if it's a wonder thing, it's probably not distressing to them. It's probably interesting and attractive to them. So remember, just because it exists doesn't mean it's psychopathology. That's where you've got to document the distress or interference. Okay, so that's how I would probably tease that out. I'm sorry, I'm just taking 1 minute to find this. I want to put this up for Joey, the book, because it's a wonderful book. And I keep it on my desk and I refer to it all the time. Of course, whenever you want to find something, right, you can't do it. Here it is. Here it is. It's the Handbook of Attenuated Psychosis Syndromes Across Cultures. And these are the editors of the book. It's a wonderful, wonderful resource. I highly recommend it. You know, there's a chapter on working with African Americans. There's a chapter on working with Hispanics, with Mexicans, with Asian Americans. It's really wonderful, wonderful resource to address those subculture things. But the other thing I want to remind you, very, very important question to always have in your back pocket when you're assessing for cultural competence, cultural differences, subculture. Would everyone else in your church, your temple, your synagogue, your family believe this the same way you do? Okay, because that's going to help you determine, are they taking it too far? It may have started out as a tenet of their religion, but maybe they're just taking it too far now. So always remember that question. Would everyone else in your church, your temple, your synagogue, your family, on your sports team believe this the way that you do? Yes, Sally.
So I'm thinking about just some situations where we've kind of been on the fence of rating someone between a 5 and a 6. And so it's clear. So for example, someone comes in, they're hearing a voice, it's distressing, it's interfering, and you kind of ask them to say, you know, how do you make sense of it? And they spontaneously say, well, in that moment, I thought it was real, but now I know that it's not real. How would you rate that? When they're
It's
kind
in the moment that it occurs. So
Okay.
when they heard the voice, what you want to know is, how real a voice was it? Could they tell if it was male or female? Could they understand the words? Okay. Could they understand the tone? Like it was an angry voice. It was, you know, whatever. And you know, if it's a 6, it's clearly formed, it's a voice, it's words, and in the moment they are absolutely convinced that was the devil talking to me. I'm sorry, Allie, you can't convince me it wasn't. It was the devil. Now, oh my God, I'm so embarrassed. I can't believe I thought the devil talked to me. Doesn't matter. It was a 6. Okay. Now, remember, just because it's a 6 doesn't mean it's a psychotic disorder.
Right.
Now you've got to look at, did it
Right.
result in dangerous or disorganized behavior, or did it meet the frequency? But you never change the rating, but it doesn't mean it makes the diagnosis.
Okay, great. Thank you.
Mhm.
Could this be like an example then of BIPs potentially, where we have clients who they're reaching 6, but the frequency is not there and it's not dangerous or disorganizing?
Absolutely. So I just had a young man who, you know, during the height of COVID, when everybody was home isolating, he was binging some Netflix show. And while he was engrossed in this, you know, marathon of watching this show, he really got caught up. And for a brief minutes, he thought the characters in the show were in the room with him interacting. And for that 5-10 minutes, he was fully convinced that it was real. That was a BIPS. It was a 6 in the moment, but it wasn't dangerous or disorganizing, and it didn't last long enough to get him a diagnosis of a psychotic disorder. But it certainly alerts us that he is at risk with too much stress to become psychotic. So you definitely would want to recognize that risk.
Barbara, I have some questions related to, I think you mentioned it early with dissociative disorders. We're seeing a lot of referrals for clients where we're struggling with a differential about if this is more of like a depersonalization, derealization disorder, or better accounted for but on like P1 with CHR. And I'm just wondering your thoughts on specifically the DSM criteria for a person to have met criteria for depersonalization, derealization, reality testing must remain intact. And some of and that's why people are being referred to us, where providers in the community are concerned that in those moments where the person's distressed by some of their experiences of like, am I real? Questioning if their hand looks sort of distorted in the moment of feeling quite distressed by that. There's a lot of moments of maybe thinking this could be, the insight is lost in those moments briefly, but there is suspicion that they could be meeting criteria for depersonalization, derealization disorder.
Yeah. One of the biggest, so right now, 3 out of 5 people that walk through my door for a SIPS come to me saying, I have DID. There are very sexy videos on TikTok that all these kids are very attracted to, and they very much want that diagnosis of DID. And it's really interesting because there's actually an app that you put on your phone, and your alters can check into the app and describe themselves. That is not DID. Okay, if you know all your alters and you know when you're in an alter, that doesn't meet the criteria for DID. So you've got to be very, very careful. True identity disorder it's rare and it's very specific. But derealization, depersonalization is very prominent in CHR. So you really have to be very familiar with the criteria, all of the criteria for DID, and it's not easy. I mean, sometimes it can be a difficult call, but I'll tell you what I find all the time is that young people assign personalities or characters, so to speak, to their different emotions. It's actually a coping mechanism. It's like, well, Barbara's kind of helps everybody and she's soft and she's kind. So when somebody's being mean to me, I need Bobby because they can stand up to people, That's not dissociative identity disorder. So you really have to be careful. And one of the things, I find this all the time, language is very interesting. People say, I feel. What they really mean is, I think. So be very, very careful with that. Make sure you understand what they're saying to you. I feel like I'm disconnected from people. Tell me more about that. What is it? It's probably a thought. Okay. And you want to really narrow in on that. They sense it, they feel it. It really means they think it. So make sure you're clear on that too. So you guys obviously are doing lots of SIPs because you have lots of great questions and all the difficult areas, And again, I just want to remind people, please don't ever forget that risk assessment in serious mental illness is an ongoing process. We know it changes. Don't feel like, oh my God, this isn't what I thought last time I saw them. I must have done this all wrong. That's not necessarily true. Like Michelle said, just because they get better doesn't mean it wasn't accurate to begin with. Okay, you really have to recognize it's fluid, it's unraveling. There are going to be changes. You know, right now there's I don't know if people are aware, but the new acronym, there's so many acronyms in the work we do, but the new acronym is ESMI, early serious mental illness. So if you hear that, you'll know what it's the same thing we're talking about. They've just found a new label for it. And they're putting together a new, you know, one of those expert panels on this. And hopefully, you know, when we draw from everybody's data, it's going to help us produce more products that we can use with this population, more products that help us make that differential diagnosis and really hone in on all these little differences that make a huge difference, you know. Any other questions or things we should review? I mean, I think these have been great discussions and probably things we've all run up against doing a SIPS, you know?
I've got a couple of questions.
Sure.
One is just about the effects of treatment, I guess particularly like medications on on a rating. You know, like somebody, gosh, I mean, it's like sometimes there's a clear effect of a medication on some kind of presentation or symptom, and sometimes it's a little bit more vague. You don't really know. Like, for example, somebody just started taking Prozac like 2 weeks ago, never taken it before. They just started taking it, and as soon as they started taking it, they're like really fatigued, you know, and it's sort of overlapping with some of the stuff you might get in the G symptoms. So that's sort of a clear situation where you know you can feel pretty confident that the medication is affecting the particular symptom. Then you know, how do you take that into account in the rating? But then of course there's other situations
Never
where it's a little bit less
ever
clear.
change your rating because of the why. Never ever change your rating. I am rating fatigue. Is it present in the past month? You rate it. Okay, never ever change your rating.
Got it. Right. Oops.
But just to clarify, oh, sorry, Zach, you can keep going.
No, go ahead.
Just to clarify then, Barbara, when you're trying to make a diagnostic decision, though, you'll contextualize maybe that you just started prescribing that medication in the decision, despite it being rated as such, let's say like a 3 or 4.
Right. When you get to the fourth box in the bottom of the P items, where you have to say, is this better accounted for? Then you talk about the why. Okay. And remember, the DSM-5 not only outlines psychiatric conditions, it also diagnoses things due to medical conditions or side effect of medications. So if it meets the DSM-5 criteria for being better accounted for by a medication adverse side effect, then you would check the likely better accounted for box. So then it does come in, but never at the rating level, only at the diagnosing level.
Yep. Okay. That's consistent with other things that we've discussed. So
yeah.
Makes sense. Then my last question is really just kind of a general question about N4, experience of emotions and self. So I've had a few conversations with folks who are learning the SIPs recently, and you know, people who know the SIPs well, about just like what the symptom is and looks like. And usually the conversation comes up when we're trying to make a rating, and it's sometimes feels like the anchors on the more mild end of the spectrum for N4, they don't like as obviously cohere with the anchors on the more severe end like some of the other symptoms do. Like it's not like a little bit sad, or like a little more sad, really sad, severely sad. You know, it's like feeling distant from other people is like, I'm looking at for number one. And then for number six, it's just like feeling profoundly changed and possibly being alien to self. So I just, the symptom is something that I think a lot of people who I interact with like have maybe just like had less experience with clinically, like on the more severe end. So if you could just like speak a little bit to
Yeah,
the
I
nature
think
of the
you bring
symptom.
up I think you bring up a good point. I think a lot of times, one of the things I always say is if you don't understand the true definition of the item, it's very difficult to rate, right? Because you don't know what you're rating for and what exactly you're rating. And experience of emotion, you are really rating their internal experience of their emotions. Are their emotions disappearing? Are they flattening out? Are they becoming harder to distinguish? Very frequently, what I'll hear from somebody is, well, I knew I was feeling bad, but I didn't know. Was I sad? Was I mad? Was I bored? Was I frustrated? They can get the happy bad, but they might not be able to distinguish within the bad. And that's like the 3 or the 4. A 6 is, I have no idea. I can't even distinguish happy and sad. I cannot distinguish my emotions. I can't feel them. I'm so flat. I have absolutely no highs and lows. Okay. So it's your internal interpretation of your own emotions. Are they feeling less strong? Are they flattening out? Are they disappearing? I'm different. I don't know what's wrong with me, but I am profoundly changed. There's something going wrong. I'm not who I am. You would definitely want to rate that there. As opposed to the item before it, which is how they express their emotion, which the two things can be very different, and I think sometimes people blur them a little bit.
I have another question unless anyone else has one. Allie, did you have one you want to ask?
No, go ahead, Lauren.
Oh, okay. Mine was about the GAF ratings. We do use them, and maybe it's because it's more of like research. We use this to track, and I just wanted to get some clarification on, I noticed that it states like even if there's passive SI or hallucinations present, that a person could have a quite a low rating on the GAF. And I wanted to just see if you had thoughts, if I'm understanding it correctly. If someone is having hallucinations, that do you immediately go, for example, to and I have it pulled up too. I think it's like I don't know, it's a very low rating of like serious impairment.
21. It's a 21. Yeah. Now, remember, hallucination is a 6 intensity with full conviction. If it's not a 6 intensity with full conviction, it's an illusion or a perceptual abnormality, and it won't meet that criteria. Okay. So Dr. Hall, I can teach people how to do the GAF. I have a much harder time justifying why Dr. Hall authored it the way he did. So I always refer people to his own article about it. Okay. But that's why I stress in the SIPs, it's not intended as a clinical measure. It's nothing you would ever share with the patient or their family. It's only to determine whether they meet GRD. And you really got to do it GAF for dummies. You don't use your professional interpretation whatsoever. It is a checklist. This is the first symptom. Serious suicidal act with clear expectation of death. And in the parentheses, he defines that for you. If it's not a yes, Don't read anything else in the box, because I'm telling you now, I've tripped myself up. That symptom is no, but some of the ones under it is yes. So if they're self-harming, I want to stay in that box and I can't. So you really have to do it the way it's intended, as a checklist. The first symptom only. Is that truly a yes? If it is, then you stay in the box. But if it's not, you have to keep moving forward.
Can I just share the screen for a moment just to take a look
Yeah.
at that specific one? Okay. So you're saying, Barbara, on 20 to 11, this rating scale, so you would always be starting with this first. So if that person in the last like 30 days has had a suicide attempt without clear expectation, if they don't, you're not going even to the question about
You don't
self-mutilating.
read anything else. You only ever read the first symptom.
Mhm.
If that's a yes, then you stop. You stay in that box and you answer yes or no. Put your yes or no right out here to each of those. But if this is a no, don't even read the box, because you definitely will confuse yourself. And be very clear. If you would go up a couple of more for a minute.
Sure.
Next one, the mild, yeah, moderate, right there. Now, look at how he defines this. Frequent depressed mood and insomnia. If it's not both together, you can't stay there. Up here, he'll say mild or lessened depression and or mild insomnia. Here, it can be either or. Here, it has to be both. He's very specific. He does not let you use your subjectivity at all. This is literally a checklist. So right here, if a person has had one panic attack in the past month, you're here. You can't leave because it's occasional anxiety attacks. You're there.
Mhm. And this one, I think this is where I see more the passive SI, the some hallucinations, but we wouldn't even be getting there. And
You
if I'm
wouldn't
understanding
get there if this symptom isn't a yes.
the serious impairment.
Yeah,
Of
if you
course,
don't get that first yes, you're not reading any of this, so you'll never get to passive suicidal ideation.
I see. Okay. Thank you for clarifying that.
Yeah, no problem. It's a tricky one. People get confused all the time, you know, and then that one box, just so you know, there are 3 primary symptoms. If you go to, I think it's the 21. No, one more. Oh, no, that's it. That's it. Yep. Suicidal preoccupation or frank suicidal ideation with preparation, or behavior considerably influenced, or serious impairment. If any of those first 3 are yes, you stay in the box. That's the only one like that. Well, I hope this was useful for you all, because it was for me, because your questions really bring me back to why the assessment was authored the way it is. And we always forget the research that went into driving the standards and the convention. So when you ask me these questions, it really brings me back to that, you know?
Thank you so much, Barbara. I think this has been very, very helpful. I will say, I mean, the GAF information is new to me. I do think within our clinics, we have been rating the GAF regardless and thinking that it would map on to the GAF that's connected with the DSM. It sounds like you're saying no to that. And
Well, I guess I don't want to go that strong, Michelle. I'm not saying no, because this is a standardized GAF. Dr. Hall did standardize it. It is a GAF. I don't think it's a GAF that's used commonly in clinical practice. I think there are other forms of the GAF that are used more in clinical practice, but the reason his GAF was chosen for the SIPs is because the inter-rater reliability on it is astronomical, because he doesn't let you use your subjectivity, you know? So there are many people who use the GAF as they do it anyway. But for diagnosing the purpose of the SIPs, you don't need to do it if they don't have a family history or schizotypal. So I'm not implying you can't do it. I'm just letting you know, for the purpose of the SIPs of making the diagnosis, if they don't have a family history or they don't meet schizotypal, the GAF is irrelevant.
That's super helpful. And I think we'll probably talk about this in upcoming like team leaders meeting, but I think we'll probably continue to collect a GAF for everyone, just because it's a measure that has, I mean, and you know, if this version is the most reliable version, it's a measure of their global assessment of functioning, which is
Absolutely. And Lord knows there is so much research about the lower the GAF, the higher the risk for conversion. So there's a purpose for assessing a GAF, you know, there certainly is. But when I'm teaching people about how to keep the SIP shorter for the purpose of diagnosing, it's one way to shorten the time, because you don't have to do that. It's not going to alter your diagnosis, you know? So again, it's depending on your purposes. And in research, of course, the more data we have, the better, you know? Anything else I can help people with today? And again, you know, if you have questions, I mean, Lauren and I do this often, you know, we'll email back and forth, and, you know, I try to get to it as quickly as I can. I mean, I'm not going to lie, I am pretty busy, so I might not get to it immediately, but I do try to get back to you in a reasonable amount of time if you have questions or concerns, for sure.
yes. I have a additional question that
Sure.
just came up. Is there a centralized place where the SIPs that has been translated to other languages can be obtained? So
No, there isn't. You got to go through me. I'm the central place. And again, because the SIPs is copyrighted and it can't be shared with people who aren't certified in its use, we just don't put it in a access to public format.
So actually, the answer is yes, there is a centralized place, and that place is you.
Yeah. Okay.
And therefore, I mean, I know, you know, can you send us whatever the official Spanish language version of the SIPs is? And then I'm also wondering from the group, what are other languages that we have capacity for that we would like?
Yeah, so I can send you the Spanish SIPs. It's an older version. The current version of the SIPs is 5.6.1. The Spanish version is 3.0, okay? And the Spanish version is formal Spanish, okay? We are working on getting it translated in a different dialect of Spanish, and with the more current version, but it isn't there yet. But I also want to, they're working on it now. So the process is one group translates it into the new language, then another group has to translate it back to English, and then it has to be given in both languages to the same people to make sure the diagnosis is the same. So it's quite a process, because it's not just translated, it's also validated. But
Yes.
some people don't realize this, and I don't say it enough, and I'm trying to be better about it. You can use an interpreter to do the SIPs in any language.
Huh.
The only thing I will caution you, even sign language, okay, is when you use an interpreter, it's definitely going to make the SIPs longer. So what I would say to you is you might want to break that SIPs up into 2 sittings. Do the overview and the family history in one sitting, and then do the SOPs in the other sit. Because, think about it. If I'm doing it with an interpreter, which I do often, I have to read the question exactly as it's written in the SIPs. Now the interpreter says that to the person. Maybe they don't get it. They ask the interpreter a question. Now the interpreter asks me the question. I explain it better. It goes back. It definitely elongates the length of the SIPs. So you need to be cognizant of that. And the same with the ones I've done with American Sign Language. It definitely takes longer. So I always break it up into 2 sittings.
That's super helpful. And are there efforts to translate it, the newest versions into other languages that are underway? Because that would be something we're very interested in. Massachusetts is expanding our access to, um, to the evidence-based assessment in languages and in increasing our capacity for having providers that can do the assessments in those languages directly. So what are the next ones that are likely to become available?
It's really interesting because it's one of those situations where there is not funding to do translations, and currently there is not. I'm not saying it's not impossible to get it, it's just not there now. So basically what has to happen is 2 different groups have to be willing to take on the project, one to do the initial translation and then one to do the back translation. So we are not currently working on, oh, that's not true. I think Italian is being done currently. Believe it or not, what's happening now is people are translating the mini SIPs into different languages. So we do have a couple of those underway.
Right. If there's anything, well, first of all, one, if we can somehow collaborate with you guys to try to help increase the availability, like if we were to find funding somehow for that, and if you have any sense of what the budget for something like that would entail, like that would be super helpful. Like if you have other folks who have applied for funding, gotten funding, and like we have a sense of what a reasonable budget for that project is.
I got to be honest with you, Michelle, every interpretation we've done was done without funding. So some group was motivated because they wanted it. They wanted to be able to use it. So they found a way within their own organization to cover their staff time to do it, And we've never gotten funded for translation.
I'm thinking about, I'm not thinking NIMH funding, but I'm thinking Department of Mental Health funding. And
Yeah.
I think this is and should be a priority of the Department of Mental Health personally. We have several Spanish-speaking clinicians on this call today, and they should be able to have the most updated version of the SIPs to use. And
yeah, and I've got to be honest with you, people ask all the time, the prime screener is just 12 questions.
Yeah, we
It's
also
so
offer
useful. And
yeah.
people are like, how come you don't have it in Spanish, And we don't, and not because we don't want to, but because there's no funding to get it done or resources at the present time to get it done,
I'm very interested in seeing the prime screen translated to Spanish, as well as the most recent, I mean, certainly we don't want to duplicate efforts that other folks are already doing, but I do, if, I can be in position to find some funding within Massachusetts or a foundation or something like that, it's something I'm very interested in doing. And I'm guessing there's other folks on this call that would be really interested in that. And that anyway, I just want to put it out there.
And you know what? I'm glad you brought that up, Michelle, because I am going to be part of this ESMI expert panel, so to speak. And one of the things we're charged with is developing materials and products. So I'm definitely going to put that on the agenda because I absolutely agree with you. I think all the materials should be first available in Spanish, and then we work our way through the other languages as well. I think it's critical to make it effective. And, I think it's ethical to do that, and, it's interesting because you and I were talking earlier about the psychs, and because that is so many sites across the world in so many different languages, that the psychs is getting translated into a lot of languages. And so it would be nice if we could do the same thing with the SIPs. Yeah.
Absolutely. And it's good to know that the psychs is being translated because that actually is relevant for some of our sites as well. Like, especially if we were to increase our capacity for ProNet to see, and do evaluations fully in Spanish, that would be amazing.
Yeah. And if ProCan gets funded, it's going to be a big issue, and especially because ProCan will definitely have the SOPs being done. I think it's going to be like every other week. So, we're going to be doing them constantly.
Yes. Thank you so much. And yeah, I just really appreciate also this whole group, awesome questions, and 3-hour meeting is no small deal.
Yeah.
For anyone.
I mean, great questions, guys. You really could have put together a master class on this. I mean, you really came with great questions.
Well, thank you. I hope you have a good, wonderful rest of your day. Maybe we can make this a yearly tradition. We'll do, a SIPS training once a year and an advanced SIPS training once a year. And I think, as long as we have our, SAMHSA funding to sort of cover some of these things, it's really, really valuable for our teams across. And it's been really valuable for me to hear the questions from folks that are at other centers as well.
Yeah. Yeah. And again, like I said, even for me, it really brings me back to what was the research? What was, all the things that went into the predictive validity of the SIPs, the construct validity, the sensitivity. You're bringing me back to all of that. And, 26 years later, you forget about that stuff. So I think it's important to have these discussions,
Fantastic. Thank you. Have a good day. Good weekend, everybody.
Thank you, Barbara.
Great
So
seeing
Thank you so
everybody.
much.
Thank you.
Yeah.